Welcome to our Mary Greeley Primetime Alive presentation, Sleep and Aging. I'm Vicki Newell. I manage the Primetime Alive program here at Mary Greeley. Our presenter today is Edward Clemmons. I should say Dr. Edward Clemmons. Dr. Clemmons received his bachelor's degree from the University of Iowa, his Doctor of Osteopathic Medicine from Des Moines University, and completed an internship in internal medicine at the University of Iowa. He also completed a residency in neurology and a fellowship in sleep medicine at the University of Iowa. Dr. Clemmons joined McFarland Clinic in 2016 and is also currently the medical director of Mary Greeley's Sleep Disorders Center. Please welcome Dr. Clemmons.
Hello, everyone. Welcome. We will try to keep you inside as long as humanly possible, and you'll get to stay for all our meteorologic updates as we go on today. Currently 94 degrees outside. A lot of the things we're going to talk about, if you saw this presentation, I did it about 6 years ago, and there's going to be a lot of similarities. To be fair, our information about sleep and aging hasn't changed a whole lot. But what we know and what we've learned is kind of some of the different things that we can do in terms of how our sleep patterns adjust throughout the years, and then also what we can add in terms of treatments. Certain treatments have changed for certain sleep disorders. A lot of the things that you're going to take from this are kind of what are the changes you should expect and what are the changes that we would consider abnormal as we age in terms of our sleep. And then when should we contact our doctor to say, hey, I'm concerned about what's going on with my sleep patterns, okay? So we have to start with a lot of kind of morbid questions, which is how old were you expected to be from the day that you were born? And what we found is that, you know, if you were born in 1932, your life expectancy at that time was 61 years old, 67. It had only changed about 6 years. But now if you're born, it's 77 years old in the state of Iowa, which is 20th best in the country. For those who are wondering, Hawaii is the best state to be born in. Your life expectancy is 81 at birth. And so what has changed by knowing that our length of life has changed is that we're learning a lot more about how the brain evolves, how the brain changes, what kind of neurodegeneration we can expect, and how that affects our sleep. One of the things I often tell my patients is many of you have beat the curve already. From the moment you were born, you have destroyed the curve for how long you were expected to live. In fact, our life expectancy in Iowa was actually up near 80 a few years ago. And then a little thing called a pandemic happened and actually drug the life expectancy back down because there were so many deaths of younger people associated with it. So what is normal aging? And I think this is one of those questions of what should I expect, right? And one of the problems that we run into is that normal is a perception, right? Normal isn't something that we can assign a value to, or we can assign a pattern to. How old do I feel? How much back pain do I wake up with? Do I think a storm's on the way because my right knee hurts? Am I not feeling mentally as sharp? People associate these things with signs of normal aging. But aging in its truest form has nothing to do with what the number is when you add up your date of birth to today's date. It actually has to do more with how long can we expect to live from this time forward? And that's really morbid when you think about it. What is my distance to death, right? Are we minus 20 years to death? Are we minus 10 years to death? Are we minus 3 years to death? And the problem with that is we don't know. We don't know. No one knows when your number is up. And so when we look at aging, it really is more how long do you have than how long have you existed? And that is where we get into a lot of difficulty describing true normal. So what confounds healthy sleep with aging? The biggest thing is pathologic aging. As we age, we tend to have more medical problems, okay? You get, maybe when you're younger, you have a little cholesterol, you have a little thyroid problem, or you have a little blood pressure. But as we age, that tends to build on top of each other. In addition, a lot of people have heard a lot recently that we have a lot more Parkinson's disease than we ever had. And some people think, is there something in the water? Is there something environmentally that's happening? And the easy answer is, no, we're living longer. We're living longer, which is what's causing us to have more Parkinson's disease, have more dementia, because these are conditions that have to do with the brain basically trimming away dead or dying material. And so because of that, we start to have symptoms of those processes happening. Additionally, heart disease tends to build up in our 50s and 60s. Cancers tend to present themselves later in life as well, especially males with prostate cancer. That tends to be one that happens a lot later. And because of that, we get put on a lot more medications. I hate to tell you how many people I see in a day that have 10, 12, 15 medications on board. And the problem with medications is they can lead to changes in your sleep patterns. And we'll talk a little bit about that in a bit. You can see some of the numbers here. 36% of women, 37% of men between 75 and 85 take 5+ medications. Of those taking at least one prescription medication, about half are taking something additional over the counter, a sleeping medicine, a pain medicine, or a dietary supplement. A study of 128 older men showed that 60% of them were on an unnecessary medication, a medication that wasn't treating anything. And just, this is the problem that happens in medicine in general, is that we get started on something and we assume that that's treating something, and we don't ever go back to look. We add something else to the process. You have to really look at the whole picture of the patient to try to figure out what they should be on. The physician desk reference, if anybody remembers that book has not, I don't even know that it's still published. It's about this thick. But I remember my grandmother had one. If she got a medicine, she'd whip out the PDR and start looking up the medication. It has 584 medications in the last one that could contribute to drowsiness. So it's a lot of medications to deal with when we talk about sleep changes. So what should sleep be like? What should I expect? What should I be doing? Okay, so there's this magic number that people think exists of how much sleep you should have. And that number is 8 hours. Everybody thinks it's 8 hours. And if you look at a bell curve for sleep across the entire population, 7 to 9 hours is about right. But as we age, as we get above 55, that curve starts to either widen or shift, depending on how you look at it, and it tends to shorten. If you looked at total hours of sleep, it may stay about the same, but again, that's where I think it widens a little bit, because now you have to start mixing in something you can't do at a younger age that you now can do once you've retired. Take a nap. There's not a lot of napping going on when you're younger, and so that total sleep time probably stays about the same. But one of the bigger things that, in really a big press in neurology, is how do we increase the amount of slow wave sleep or deep sleep a patient can get? And the reason for that is we know that's actually when the body flushes the trash out of the system. And so as we age, the slow wave sleep, or the third stage of sleep, actually decreases pretty dramatically. Now, you don't have a lot to begin with, but as a younger person, it's usually in the 9 to 10% of your sleep range. As an older person, it actually goes totally away most of the time. And so we know that that's actually when the body's actually trying to clean itself out of some of the trash that the cells in your body is trying to take out of your brain. And so we wonder how much of that actually contributes to some of these neurodegenerative diseases that we see, from dementias and Parkinson's disease and things along that front. The other part that really changes, and this may be something that I hear probably 50% of my day, is we wake up a lot more. We fragment a lot more. It may not be long. It may just be a few seconds or a couple minutes or even just a short, I went to the restroom, I went right back to sleep. But we do that a lot more as we age, and that's called WASO, or waking after sleep onset. And so even though you may feel like you sleep the right amount of hours, you may just fragment more, in which case that changes the overall sleep architecture that you should expect. And I'll have a graph of kind of sleep architecture here in a little bit. The other part that changes is that people are actually prone to sleeping at different times. We'd love to say that everybody goes to bed at 10 p.m., wakes up at 6 a.m., but that's what society said you were supposed to do during your working hours. That's not what people actually want to do. A lot of people want to go to bed later, night owls. A lot of people want to get up earlier. My grandfather would always get up at 5 in the morning and be making the coffee, and he'd go to bed after Johnny Carson was on. I mean, that's a very short amount of time, but what did he do? He took a nap in the afternoon, and so it was fine. He lived to be 92. He died of heart failure. It had nothing to do with his sleep, but it's one of those things where people can be morning larks, they can be night owls. Not everybody falls on a perfect spectrum, and that's why I don't say that a quantity of sleep matters. It really matters the quality of sleep that you're getting. Hey, I told you there'd be a picture. All right, so it's don't worry so much about this part of it. But here is, when we're looking at this graph, what you're looking at is, this is the aging spectrum, okay, on the bottom, and this is the total sleep. So when we're very young, we need lots of sleep. So after I leave here today, I'm actually going up to Gilbert Schools to drop off and do the school pictures thing for my 9-year-old and my 7-year-old. Now they think they need 5 hours of sleep a night. They're wrong. They need about 10 hours of sleep. And we try to get them in bed by 8. They're up like clockwork at 6 in the morning. And that is what they need. Now, as you can see, if my mouse would stay on the screen, there it is. All right. As we age, the total amount of sleep we need goes down, okay? So here's that magic, oh my God, we need 8 hours of sleep. There it is, right there. But you can see that WASO, that waking after sleep onset, it starts to increase in the amount of total wakings that you're having. That REM, this is that super deep sleep you have, starts to shrink down too. But this is the one right here. This is that N3, slow wave sleep. And you can see, you get out here to 85, and it's just ever so small how much truly slow wave sleep that we should be getting. Stage 2 stays about the same the entire lifespan, and stage 1 is very brief and usually is a transitional phase that lasts about 5% total of your sleep throughout your lifespan. All right, so why does my sleep change? For the same reason that people get dementias, for the same reason that people get Parkinson's disease. The short answer is your clock breaks. Your clock breaks. The brain just isn't as well connected as it once was. And so a lot of what drives that, and here's the long answer, is there's two things that drive your sleep. One is your homeostatic sleep drive, okay? Homeostatic sleep drive, the easiest way to think about it is when you wake up in the morning, you should be 0% likely to go to sleep because you just got done sleeping, okay? Throughout the day, it goes up in a linear fashion, and come bedtime, it should be you're 100% ready to go to sleep, okay? So it is a linear thing that says the longer that you are awake, the more likely you are to go to sleep, okay? The other one is your circadian cycle. And so you have 2 circadian cycles per day, and it's based on body temperature and the sun, okay? It's the greatest clock setter we have. That's why I tell people, if you aren't sleeping well, don't sit in a dark room. Open up the shades, let the sun in, not when it's 100 degrees and cooking you. Don't do that, but try to get yourself awake or in the early morning and then start to dim it at night so that your brain is transitioning the way it's supposed to, okay? So that piece of it, that circadian piece of it, on that second cycle during the day, this is why the nap, people want to take a nap, is that second cycle, it starts its upshot. your homeostatic sleep drive has reached about 50 to 60%, and you're like, I could go to sleep. And so you naturally want to go to sleep in the afternoon. It's what your body should actually want to do. Everybody, I want to take a nap. Maybe not right now, but in about an hour, I'll probably want to take a nap. Everybody should want to take a nap because your sleep drive has gone up and your circadian pattern is catching it. And once they cross paths with each other, you should want to go to sleep. So, the circadian pattern is driven by hormones. The most classic hormone is something called melatonin. If you've been to your local supplement section in the grocery store, you've probably seen melatonin being sold. Comes in 3 milligrams, 5 milligrams, 10 milligrams. What that's meant to do is when you're sitting in dim light at night, you're sitting and there's a little table light next to you and you're watching your TV or whatever, at about 7 p.m., if you go to bed at 10, your melatonin starts to kick out of your brain from a gland in your brain called your pineal gland. And when you take melatonin, you should take it a couple hours before bedtime if you're taking it, not right before bedtime. It's not helping you. Because what it's trying to do is bend your melatonin curve so that you are more ready to go to sleep. What ultimately happens is those connections in your brain that melatonin works on, they start to break down. They start to get fragmented. They start to get little shorts in them. Think about wires in your house. If you started clipping them with little pairs of scissors, your signaling wouldn't be good. And so because of that, you start to lose sense of what the clock is supposed to be saying. And your brain starts to lose sense of when it's supposed to be asleep. In addition, as we age, whether it be, it's volitional to some extent, we also get less light exposure. We go outside less. Younger people tend to spend more time outside, tend to spend more time commuting in cars where they're getting sun blazed on their eyes. As we age and we're retired and we don't have to be out when it's 100 degrees, we don't get the sunshine exposure to tell us it's time to be awake and set that clock naturally. So as you can see, older people average an hour less light exposure per day than younger people do. And some of that can be also because of environments that we live in. So when you think about some nursing facilities and things like that, they're not the glass budget wasn't high when it comes to putting in the windows. There's just not a lot of light coming into some of these places. And then the other thing that we already talked about is the societal cues. You don't have a job that says I have to get up at time X anymore. You don't have kids that you need to get off to school anymore. You don't have those things that tell you this is how your clock structure needs to be set. And so it breaks down. So what sleep disorders are most prevalent in the advancing age population? About 30 to 50% of people will present with a sleeping difficulty. Two primary ones tend to exist: insomnia and obstructive sleep apnea. Okay. There are other ones. There are other classes of them. Circadian rhythm disorders, like we already talked about. You could be a overly night owl. You want to stay up till 3 in the morning and go to bed and wake up at 11 in the morning. That's not abnormal. It's just your circadian rhythm shifted. Restless legs is another classic one that is a sleep-related movement disorder that can happen. These are the two most common ones that we hear about. Insomnia, a lot of reasons for people to have insomnia. Medications can induce insomnia. Psychophysiologic is probably the biggest cause of insomnia. And what that means is essentially the bed space, the bedroom becomes some sort of a torture chamber. Your brain has been programmed that I'm not going to be able to sleep in here. And it's usually between the ears is why that's the case. There's a 3P model that we talk about, which is predisposing factors, age, being a female. These are kind of two of the bigger ones that we talk about that make you more prone to having insomnia. There's a precipitating factor, usually, something that you sometimes can put your finger on. Oh, I went through a medical procedure and I've had trouble sleeping since that procedure, or this loved one in my life died and I've had trouble sleeping since that happened. And then the third P of that model is perpetuating factors. There's something that keeps the cycle going. Either we get off of our normal sleep hygiene habits, we try to induce better sleep by using medications, different things that we allow to continue the cycle and don't break the cycle of our poor sleep. The other one is you can just have ailments that cause you to not sleep as well or not be able to fall asleep. Pain, arthritis, acid reflux, heart disease, lung disease. You have to sleep sitting up in a recliner instead of sleeping in a chair or instead of sleeping in bed because you can't breathe when you're laying flat. Different conditions like that can cause problems. Obstructive sleep apnea, for anybody who knows, obstructive sleep apnea is where the airway closes while you're trying to go to sleep at night, and it can do that many times an hour. The treatment for it is usually CPAP therapy, although there have been some advances along that front as well. Insomnia resulting from medical conditions and medications. The biggest one is psychiatric conditions, depression, grief. Depression is a incredibly strong and unrealized factor as we age. A lot of people get told they probably have a dementia, and in reality, what they're actually experiencing is depression. It's the one thing that we know that if you treat the depression, you can actually make the thinking better. One of the 9 symptoms of depression is, in fact, changes in your sleeping habits. And so that is one of the biggest things, the biggest coexisting problems that does exist in the setting of insomnia. In addition to it being present in insomnia, insomnia is also a risk factor for development of depression. So it's a chicken or an egg phenomenon. We don't know which one comes first, but it's 8 times as likely that you'll be diagnosed with depression if you're dealing with insomnia. The signs that you would be thinking of if you were going to ask your doctor about your insomnia: difficulty falling asleep, feeling like you're waking up way more often than you should in the night, and then waking up much earlier than you would expect to. I went to bed at midnight and I'm always waking up at 5 a.m. That's a really short time. Even when I tell you that total hours of sleep doesn't matter, 5 is still a pretty short amount of time to expect to be asleep. Grief and bereavement are a very special consideration in the population because as we age, we start to lose people who are close to us. And that's the nature of aging with friends that are similar in our age. Insomnia is reported in up to 10 to 15% of people within up to 5 years after losing a loved one. And so that's really important to realize that there are the psychiatric implications that could be affecting your sleep. I think oftentimes what happens in the primary care world is they're overwhelmed, okay? I'm not family practice, internal medicine. They have a lot going on. They're trying to keep your blood sugars under control, your blood pressure under control. And you say, I'm not sleeping well, and they say, take this pill, right? This is gonna make you sleep better. And in those meds that were designed for sleep, whether it be the Ambiens and Zolpidems of the world, or Azopiclones, or Lunestas, or Sonatas, they're meant to be used in the short term. They're meant to be used for no more than 3 to 6 months at a time to try to get your sleep schedule back, because chemically inducing you to sleep is not the same as what your brain wants to do on this chart. And so we do look at those things and say, try to avoid the medications because they're probably going to cause the problem to prolong itself. Medical conditions wise, I mean, a lot of the things we kind of already mentioned. Pain in and of itself can certainly disrupt sleep. 20% of people describe sleep disruption multiple nights per week due to pain. I saw somebody earlier today, and they're like, I take an ibuprofen every night. And I say, why are you taking ibuprofen every night? My body hurts. I mean, that's not treating an ailment. That's just treating a symptom. But I was seeing them for their apnea, and it's like, it helps them ease into it. It helps them get to sleep because they know their sleep is disrupted from the pain that they experience. And so I think that's one of the things that we'll never be able to take away. I'd love to sit here and tell you I have some magic pill that's going to make pain disruptions of your sleep go away, but that's unlikely. Acid reflux can certainly be a sign of sleep apnea. I've had people be able to get off their acid reflux medications by treating their apnea, but in addition, that waking up with that acid taste in your mouth, it can cause irritation of the airway, irritation of the throat, things that can wake you up throughout the night. As we talked about, different hypoxemia, inability to breathe with heart disease, lung disease, prostate disease especially causes a difficulty with needing to get up to use the restroom. Getting up to use the restroom at night, twice is okay is the mantra, 3 times is too many, more than 3 times is completely excessive. And so trying to get at why that would be the case. About 50% of people that have untreated sleep apnea actually have symptoms of frequent nocturia, a need to get up to urinate in the night. Biggest meds in this in the population that cause drowsiness: anticholinergic agents. If you're on oxybutynin for overactive bladder, or you're taking Benadryl to try to help you sleep at night, that's what they're meant to do, certainly. But it can be far more problematic than even helping you sleep, as it can cause difficulty with cognition and overall sedation during the day, which leads to more sleep during the day, which throws off your sleep even more at night. Other classes of medication that cause a lot of difficulty, as we talked about, antihistamines, where that Benadryl sits, hydroxyzine, any of the PM medications, Tylenol PM, Advil PM, ZzzQuil. They include a drug called doxylamine, which is an antihistamine meant to help put you to sleep, but certainly can cause long-term effects of drowsiness during the daytime. Muscle relaxants, I tell people they don't relax your muscles, they just put you to sleep. So Flexeril, Tizanidine or Xanaflex, they are really good at making people drowsy. Antidepressants are tricky. They help people be more drowsy, but they also change the dynamic of how that sleep architecture we looked at earlier goes. Antidepressants actually decrease your deep sleep. So when we talk about the deep sleep being necessary to fend off cognitive issues, to fend off neurodegeneration, antidepressants long-term actually cause problems with that sleep architecture. In fact, it's one of the drugs that I have to have people stop if we are looking for a condition called narcolepsy, or the ability to want to go to sleep at the drop of a hat, because antidepressants block your ability to get to that deep stage of sleep. Seizure drugs, not even being used for seizures. Classically, gabapentin, used for pain a lot, used for neuropathy, especially used as we age. Number one side effect of it is, in fact, drowsiness. Topiramate, pregabalin or Lyrica, which is the sister medicine, and gabapentin, same thing. Antihypertensives like beta blockers, metoprolol, propranolol, they don't make you necessarily drowsy. They tend to induce more fatigue, and that's getting into a little bit of a semantic difference. Drowsiness is the desire to want to go to sleep. Fatigue is a lack of energy or a lack of motivation, a lack of vivacity to do something. So sometimes people get put on propranolol for tremors, for family tremors. And I tell them, one of the things you have to watch out for is if you're going to go get on the treadmill, or you're going to go do something that's you want to be active, and you just can't seemingly get that vavoom to get up and do it, it's probably the medicine inducing that. Because what happens is, for you to go onto the treadmill or you to be active, your heart rate needs to go up. Beta blockers stop your heart rate from going up. They keep you at a flat 65 beats a minute all the time. And so if you need your heart rate to increase to go work out or to go do something, you may not feel like you have that energy because the heart rate stays down. Pain meds, opiates, it's a huge problem in this country, but they're one of their biggest side effects, in addition to constipation and addictive potential, is in fact drowsiness. A lot of people are on lorazepam, diazepam, clonazepam, alprazolam, or Xanax for their anxiety. They are great at putting people to sleep. And then other different neurologic medications, memantine or Namenda, donepezil or Aricept, both used for issues with cognition or with dementias. Carbidopa-levodopa used for Parkinson's disease. Side effects of them include drowsiness. Certain medications, though, have the opposite effect to stimulate you, which causes a different problem. It induces insomnia, not drowsiness, right? Bupropion, a different antidepressant, also known as Wellbutrin, can induce people to be awake. So some people will take it at night with their bedtime meds, and they'll come back to me and say, I can't sleep. Why am I not sleeping? And I say, when are you taking your Wellbutrin? I take it at night with all my other meds. That one has to be taken in the morning. It will cause you to be awake. It won't let you sleep. Even stimulants used for ADHD, used for narcolepsy, methylphenidate or Ritalin, that can also cause people to have difficulty sleeping. So you just have to take it at an appropriate time during the day. As we talked about, other medications can exacerbate other sleep disorders. Restless leg syndrome is exacerbated by antidepressants, with the exception of Wellbutrin. It is one thing that we know. Alcohol, a couple days ago, met with somebody. Alcohol, wife said, I know when I can't sleep in the same bed, and it's usually after he's had 2 margaritas, because his restless legs are just that much worse, and so he's kicking around at night. So it's always good when they follow the textbook. Treatment, how do we treat it? First and foremost, we're going to try to identify the cause. I misspelled cause, I just realized that. Where are you at on that spell check? And oftentimes it is multifactorial. We can't put our finger on one thing. You know, it's not this, you got to get up at the same time every day, or you got to not take your nap. These are things we would tell you to try to correct it, but there's a lot of things we're not going to be able to correct, such as the medical issues that we've already talked about. Try to find offending medications and optimize when they're being taken. If they're stimulating you, and you're taking them at night, take them in the morning. If they're making you drowsy and you take them in the morning, take them at night. Try to get that timing right on the medications. And then, as I mentioned, we don't like sleep aids in the sleep medicine world because long-term, they're not fixing a problem. They're a Band-Aid for a bullet wound. You're just putting a Band-Aid over something and not trying to fix it. So we really try to work on the sleep hygiene aspects, work on stimulus control, make sure that on your phone, if you're on your tablet or on your phone, that you have, on Apple, it's called Night Shift. If you've ever looked at your iOS settings, there's something called Night Shift on your phone, and it actually will darken your screen as the day goes on so that it's not stimulating your brain to be awake. On an Android, it's usually just called Blue Light Filter. You don't even have to download an app. They come built in on these systems now because we know that people are sitting in bed with these things right in front of their eyes telling their hypothalamus to be awake. And as I mentioned, pharmacologic measures tend to have their own risks, which outweigh the benefits. They should only be used in the short term. Benzodiazepines, Ambien use is highest and most chronic in the elderly population and is associated with injurious falls and cognitive impairment. That's not a casual relationship. That is, we know that people that are on long-term benzodiazepines fall down and break things. That is what happens. And so we try to make sure that people are getting off those medications if at all possible. OSA, so obstructive sleep apnea. I see a lot of obstructive sleep apnea. I read a lot of sleep studies, and I read them. That's what we're looking for. It does increase with age, but peak diagnosis is in middle age. It tends to be more so in men in middle age, and as we age, it starts to increase in females. And the reason for that is as the estrogen gets farther and farther out of the system, the tissues become more lax. And so the airway can close a lot easier as females age than it could close when they were younger. Men, it is more of a body habitus problem. Big, thick necks, big chests, things that are causing their airway to close. About 30 to 40% of the elderly will have OSA. And that's about 24% in men less than 60. Snoring is not the number one sign of apnea. My mentor who trained me always used to say, what does an apnea sound like? And an apnea sounds like absolutely nothing. And apnea means there is no flow. They stop breathing and then they start again. There's no snoring is that there's some narrowing of the airway and you're vibrating the tissues in there, but apnea truly doesn't sound like anything. And so snoring is not the number one sign to look for, especially as we age. Again, as we talked about, the number one sign that is presented as we age above 60 is nocturia, getting up to pee too many times at night. AFib is another one. A lot of, if anybody has seen Dr. Rasmussen or Dr. Christensen, they've been diagnosed with AFib. One of the first things they're going to send you to have done is have a sleep study done. And the reason for that is we know that when you have an apnea, it causes a big release of adrenaline. When that adrenaline hits your body, your heart goes, I have to run from that bear, and just starts pumping. And it can actually jump itself completely out of rhythm from all those adrenaline rushes in the night. And so apnea can actually be the stimulating factor for AFib. It's 4 times as likely that you will have atrial fibrillation if you have untreated sleep apnea than if you had no sleep apnea. Frequent awakenings, insomnia, that's a little bit more nebulous. We obviously can't just put, we can't just say, oh, wakes up frequently and say they have apnea. It doesn't work that way. Cognitive impairment, though, Medicare does support that cognitive impairment is an indication for doing a sleep study because we know that the part of the brain that is most affected by low oxygen is, in fact, your memory center in your brain, the hippocampus. So when you think about even having a heart attack, and the reason for doing CPR, while very important for the heart and the lungs, don't get me wrong, it's actually to protect your brain. Within the first 5 minutes, you lose oxygen to your brain, you start to lose memory and start to have cognitive defects. And so that's why they do support the checking of a sleep study in cognitive impairment. Obesity is often considered unimportant as tissue elasticity is lost, as I said. And CPAP is equally effective, but the pressure requirements tend to actually need to be lower as we age than what they were as we were younger. And again, that actually comes down to body habitus and body size. I'm going to beat this drum. So if you guys are peeing more than 3 times a night, you got to get it checked out. So more than 3 times in a night, it has a 75% likelihood of having OSA. I mean, it's very linked to how many times you get up and urinate in the night. And it has to do, they believe it has to do with the fact that you get fluid backload against the right side of the heart that then flows back to your kidney, telling your kidney that you need to pee, and starts creating more fluid. So, and multiple studies, I again saw somebody today, I saw 13 patients using CPAP today. One of them presented with the best symptom change they've had is they've gone from 4 times a night to 1 time a night. I mean, so this is definitely something that can be easily remedied. This is, as we were just talking about, one of the reasons that we can test for OSA. The assessment of OSA patients shows similar declines to those just solely due to aging. But the biggest thing that we know is that with 3 months of optimal adherence to their machine, that they can actually show, I call it sharpening of the knife, that you just are feeling better, you're just thinking sharper. We see improvements in your thinking, your mentation scoring. Additionally, Alzheimer's disease, if you do have it, is made worse by apnea for the same reasons we already talked about, which is that low oxygen to that memory part of the brain. So. Gold standard of treatment for OSA is, in fact, CPAP. Pressures from 4 to 20, used via an external mass delivery system. Pressures do tend to be lower in the older adults. There are different types of sleep apnea. So we talk a lot about OSA or obstructive sleep apnea. If you have heart issues, heart failure issues, you may have something called complex sleep apnea, which is a mix between obstructive and central sleep apnea. You can also just have pure central sleep apnea. That's seen quite frequently with heart failure. And those need special devices to treat them. One of them is called an adaptive servoventilator or an ASV. Those cases do tend to be quite challenging. And oftentimes we have to fall back on CPAPs or oxygen therapy to get it quite right. So, Oral appliances, some people ask me, well, I hate the idea of being strapped to this machine if I have OSA. What are my options? Mild to moderate, it's approved that you could use an oral appliance. An oral appliance made through your dentist. What it does is you put it in your mouth at night and it pulls your jaw forward, opens up the anterior, posterior airway space. The biggest issue we face is as we age, not all of our teeth tend to be our own. And because of that, they don't work with false dentition. The oral appliance doesn't. And so because of it, it has to be seated and be able to apply pressure to the jaw. Biggest side effect of it is usually TMJ or jaw pain. Sometimes the dentist that will make them will give you what's called a reseating device to wear in the morning, which kind of shifts it back. It is about a cool $3,000 out of pocket for one of these devices. Even with Medicare's help, it's still probably about $2,500, and they're only about 50 to 80% effective compared to CPAP. Surgery, reconstructive, is not effective. It certainly cannot be effective in the advancing age population. And in fact, you're at greater risk most likely to have additional morbidity or mortality from having a surgery done on your airway. There is a new surgery. This is one of the new additions called a hypoglossal nerve stimulator. If anybody watched any football last fall, it was always some, I think it was an angry wife on one side of the bed because of the snoring, and on the other side of the bed was the angry man who didn't want to put on his CPAP. And it was like, we have this new option that is better than using a CPAP every night. And this is the device. What this is a pacemaker for your breathing, essentially. They put a battery pack in your chest wall. They run a wire down between your ribs. They run a wire up under your skin to the base of your tongue. You turn this thing on with a device that looks a lot like a mouse, and you get 3 quick jolts in your tongue so that you know it's turned on. When you try to breathe in, your chest wall expands. It trips that wire. It tells the battery pack to send a stimulus to the nerve in your tongue, and it tells your tongue to stick out over and over all night long. Not like, you're not like Gene Simmons out here, but you are sticking out your tongue, and when that happens, it's just like when you were a kid and they stuck the tongue compressor in your mouth and they said, say, ah. That tongue forces the airway to open up, and you can do that all night long. It's about 80% effective compared to CPAP, and it's about 90% effective for snoring. It does work. ENT puts them in. Our ENTs do not. The biggest thing is there's a lot of criteria. You have to have an apnea index between 15 and 65. Your BMI can't be more than 32. You have to have tried CPAP and failed. And then ear, nose, and throat, the otolaryngologist will put you to sleep artificially, and they have to watch to make sure your tongue is what tips into the back of your throat and causes the problem. Because if they're going to stick out your tongue to try to fix the problem, they want to know that that was the problem to begin with. Body position can be effective in mild disease. When we think about that, is usually the old tennis balls in the tube sock or the elbow trick. So you're snoring again, roll over. It can be effective, but it is often not long-term effective because the loved one will fall back over on their back and be snoring again. And they actually have done lots of studies that have shown that any of these fancy devices or even the tennis balls in the tube sock, people will still tend to, even though it should be completely uncomfortable, will still find a way to get back over on their back. They'll just train it out of themselves that they won't roll over anymore. Pharmacologic, there's no drug to treat OSA. I think I will say that for probably, let's say, 10 more years. And then I think we will have a drug to treat OSA. They have tried a ton of studies that have not been overly successful. The most recent one is a combination of a stimulant and a anticholinergic, which, based on what I told you earlier, we should not put together to go to sleep. But they found that that combination drug actually did help people overall. It's one of those things that I think we will find that we will have a better option in the future. Sometimes we do use stimulants or wake-promoting agents in conjunction with a good CPAP user if they're still excessively sleepy, just so they're safe on the road or whatever it may be. All right, I think this is it. This is my daily nap okay. It's complicated. It's probably fine, especially if you, as we talked about, sleep shorter hours. If you're sleeping 6 hours and you take an hour nap in the afternoon, you're hitting that magic low end of the number, right? 7, that's probably okay. We want to know that you're not taking that nap because of you have a different sleeping problem. You're not sleeping well at night, or you're not breathing well at night. They've done studies on both sides that have shown both sides. Napping can be beneficial and protective from certain diseases. They've shown that it can actually make it worse for certain diseases. And so I can't tell you that it's healthier for you or not healthy for you because we don't know. I tell people as long as you're napping less than an hour and you're doing it in the afternoon, I think it's probably okay. Because again, back to that circadian pattern, back to that homeostatic sleep drive, that's why cultures have the afternoon nap built in. They know that that's when you're going to get those two things together and you're going to feel like you want to go to sleep. If you tell me you're taking a nap, you wake up at 8, you eat your breakfast, you want to nap at 9:30, it's probably a bit early and you're probably not sleeping well enough at night. Napping has been associated with all sorts of things, falls, nocturia, all sorts of things. But again, it's been associated with healthy things as well. And so I don't put a lot of stock into telling people they shouldn't nap unless they tell me they can't sleep at night. It's the only reason I tell people you cannot nap. So I think if I hit next, it's going to be the end of it. Ha! I was right. All right. You got 13 minutes.
And I'm going to come around with the microphone, so give me 1 second. Some questions.
If you're already on a CPAP or BiPAP, how often should sleep studies be done?
So here is my answer to that. If you are following up regularly with somebody who is looking under the hood, I personally do not think you need to ever have another sleep study as long as someone is following your machine. There are situations where I will do them if somebody loses a lot of weight and they have some question about whether they still have apnea. I'm going to tell you, it makes me more money if we do more sleep studies. But my answer is, if you follow in the clinic where it is a copay and we look under the hood on an annual basis, I don't think people need. I've had 3 in my life and I use a CPAP every night. I check my own data. I haven't had a sleep study in 7 years.
All right. Another question here?
Yeah, I have a strange thing. I'm on 2 depression medicines and gabapentin for feet. And I can sit in my chair and be eating, like a peanut butter, and all of a sudden I'm asleep. And when I wake up, the food's on my lap. And what is that?
Well, I think the hard part is knowing when what you're describing is something called sleep intrusion, right? So when you're doing something else, sleep gets in the way, right? And that's always this question of when we talk about what are these meds doing in concert, not one alone, not 2 alone. It's not probably as simple as stopping one. Is it 10% the gabapentin and 45% this antidepressant and 40? I don't know, and no one will ever know. But there's always the concern that they are inducing a sleep intrusion when you think about it in those terms.
Thank you.
I was wondering about Ambien.
Yeah.
I know somebody's been taking Ambien for years. What's the long-term effect then going to happen?
Well, and the answer is not necessarily what is going to happen, because ultimately that involves the crystal ball that I didn't bring with me to look into. But what I would tell you is we know the risk of side effects of cognitive issues and increased falls and injury related to it, as well as the biggest side effect in the current usage of Ambien is, in fact, sleep-related activities. So sleep-related binge eating, there's actually indications of sleep-related driving. There's actually been multiple lawsuits over sleep-related driving while on Ambien. And so that's really the concern. If people end up on these meds, is it actually hastening the potential for a cognitive problem, for falling and landing themselves in a nursing home, different things like that? Another one with Ambien. So Ambien, for years, was approved up to 10 milligrams for everyone. Then they did a study, okay? Everything's a study, I get that. They did a study, and they tested females on 10 milligrams. Then they had them drive upon waking up while on Ambien 10. They drove as if they were drunk, not hungover, actively drunk. Like I think the blood alcohol conversion was something like 0.15. I mean, that's almost 3 times the legal limit from being on Ambien 10. So they now added a black box warning to Ambien that the max dose for females is in fact 5 milligrams. Do I see people that are on 10 milligrams? I do. Do I warn them of this problem? I absolutely do.
All right, another question here.
Does a weighted blanket help people sleep? What's the science behind it?
I'm not sure that I can quote you the science on it. I will tell you that yes, it does help people sleep, especially people that have difficulty with sleep-related movements, like restless legs, things like that. Anything that puts a little pressure. There's actually is some good science for people with restless legs for SCDs, or sequential compression devices. A lot of my patients with restless legs love coming to the hospital. And why do they love coming to the hospital? Because on the end of the bed, they put these devices that they wrap around your calves, and every so often they inflate and squeeze and inflate and squeeze. And that is actually more effective than medication in a lot of cases of restless leg. So anything that adds weight to the legs tends to be helpful for restless legs.
All right, Tim has a couple questions online. We'll have him do those.
Okay, the first question is, why do we dream? What are our dreams trying to tell us, and what do they mean?
I am in fact not Freud, but the reason we dream we believe to be for memory consolidation. So dreaming is caused by a neurotransmitter called acetylcholine. All right, and we have a lot of acetylcholine in our bodies, but the reason we dream is because we have all this influx of acetylcholine while we're asleep. So what is interesting is the meds that we have for memory, most notably donepezil or Aricept, is an anticholinesterase inhibitor, which what that does is it stops the activity of acetylcholinesterase, which breaks down acetylcholine. So we try to promote memory by increasing that neurotransmitter, with the number one side effect of that drug being vivid dreaming. So there's a lot of overlap between memory formation, memory consolidation, and dreaming. It's another reason that we think OSA plays such a role in cognition, because what happens if your brain's not getting oxygen is your brain won't go into deep REM sleep or dream sleep to then consolidate your memories overnight.
Second one, Tim.
Okay, the second question is, I have a friend with Parkinson's and she's on several meds. Where could she have her meds evaluated? Her Parkinson's doctor says she only deals with drugs related to the disease.
Yeah, and that's the hard part, right? Is that we need to have a better sense of the entirety, but physicians in general are very busy. I'm not going to say that we're not. I think it's hard. That's what we really anticipate primary care to help us do, is to act as a hub in this wheel to make sure that all this is being looked at together and go, gosh, this blood pressure medicine doesn't work well with your Parkinson's medication. Yes, reach out to your neurologist and ask them about this specific interaction. But that's the problem. Medicine has become very niche in a lot of ways. There's a lot of specialty. There's a lot of specialization. And I would be hypocritical to not say that I'm a specialist in sleep medicine. But it is one of those things that we really need help from our general practitioners, our primary doctors, to look at the whole picture and say, oh man, I'm worried about these two things interacting.
You've mentioned restless legs. Yep. Is there any relationship with sleep and cramping of the feet, ankles, especially at night, during sleep or waking up because of it?
There's a whole separate condition actually called nocturnal leg cramps. We're really not very exotic with our naming system. So leg cramps at night can be foot cramps, but it's completely separate from restless leg, true restless leg. The question always with nocturnal leg cramps is twofold. Is there some sort of vitamin or metabolic deficiency that's driving it? Is there something anatomical that's driving it? So if there's a low back issue, that can cause that kind of cramping problem to happen. Neuropathy can also cause that cramping type sensation and cramping problem to happen. B12 deficiencies can cause that, other metabolic things, magnesiums, different things like that. And so it really is good to look at the metabolic profile. There's not a lot of super good treatments. If you ask my grandmother, it's like putting some sort of soap under the blanket at the foot of the bed. That doesn't make any sense. But if you ask the VA population I used to work with, the biggest thing that they used to tell me, and there's something to this, I'll be totally honest, there's something to this, is pickle juice. Pickle juice of all things. Pickle juice, mustard, vinegar, it's all on that same vinegar basis, but that's the one thing that I see, honestly, more people than not get benefit from is vinegar, some sort of vinegar-based issue.
Does meditation affect sleeping?
In a positive fashion, yes. I mean, anything that leads to mindfulness, to being in tune with oneself, it certainly does. In fact, my son, every night, he's a little bit of an anxious type. He's 9, and he's scared of his shadow. But he listens to an app called Smiling Mind. And what that actually is meant to do is it's meant to tune him in and meditate him to getting ready to sleep. And it's really a great app. I mean, I fall asleep to it when I'm laying there with him, so it's doing its job. But really, the one that he's really on right now is one called Accepting, but they deal in equanimity, which is the idea that you can have an experience that doesn't affect the next experience for you, essentially, is being able to go outside of the experience and realize what has happened as part of the whole, but basically subtract yourself from the equation and be able to compartmentalize that piece and then move on with your sleeping habits. So,
What was that called?
Smiling Mind.
What measures can be taken in order to promote and induce sleep? Like they say, like a darkened room, temperature, and like chamomile tea, valerian tea.
Yeah, so there's a lot of different things, even just conservatively, that you can do. You're right. A dark room is one of the best things. No additional light. That's because it trips your hypothalamus. When we talk about temperature is a very personal preference, but I would tell you studies show that the sleeping temperature that is optimal for people is 67 to 68 degrees. People will think I'm crazy. People will think that I'm not going to run my AC that low. I get that. But the bottom line is the studies show that you sleep better, and for every degree that goes up, it tends to be a drop-off of about 5 minutes of total sleep time. So that is one of the best things. Making sure that your bed environment is one that you feel comfortable with. If you don't like your pillow, change your pillow. If you don't like your mattress, make sure that you're updating your mattress. That stuff is important. But again, is sleep number all it's cracked up to be? I don't know, but you get into a situation where maybe your bed partner likes a stiffer mattress and you like a softer mattress, and now you have a problem for what your sleep is going to end up like too. Those are the best things. I don't think teas, yes, there's no downside to teas. I don't know that there's a lot to specific science in the tea world, but there might be.
If I wanted to start taking melatonin, what level should I begin at?
Yeah, so melatonin's tricky. So melatonin, for what it's worth, it comes in a variety of different sizes, from 1 milligram up to about 5 milligrams. Is there a right value? No, there's really not. I mean, I would say start low and go slow if you're going to start trying it. It can cause you to dream some too, so be aware of that. I've had people describe daytime grogginess from taking it, although it shouldn't last that long. The most important factor with melatonin, again, is 2 to 3 hours before bedtime. If you take it at bedtime, you might as well have thrown it out the window because it didn't do anything for you. It was a placebo effect.
There's some people like myself who are just light sleepers. I mean, might sleep 6 hours a night or go to bed real late and not be able to sleep right away. So I get out of bed, go and watch TV or read, then go back to bed. Doesn't work. Get out of bed. It might take 3 times. Is that normal? Are people like that?
It's not normal, but you're doing the right thing for it not being normal, okay? So, I mean, I don't want you, the biggest thing I tell people is don't try to go to sleep,
Yeah.
okay?
Yeah.
I don't want you to go to bed and try to go to sleep because that makes it worse, right?
Yeah, I found that out.
Yeah, and so you have to do something mundane. You have to draw back from the environment because if you don't, what that's doing is feeding the torture chamber, right? It's saying I'm not going to fall asleep in here by just laying here. So you're doing the right things. Is it normal? No. Is there anything behind it? I mean, that again would probably be like a full consult on what possibly stimulated this, how long has it been the case, different things like that. You know, some people are notoriously light sleepers, and I don't think that part's probably not abnormal. It's a small percentage of people. But if you've always been a light sleeper, that's not something that we're going to probably train out of you either.
Okay.
Do you have to get going?
No, I have to leave at, I don't know. I have to have my kids up there by 4, so we got time. I got time.
Any last questions?
I can answer questions about sleep all day.
Okay, 1 second. I'm making my way over. Tim, are there any online?
No more.
No more. Okay.
Yes, I would just like to say that one thing that I find helpful sometimes is deep breathing. I try to do abdominal breathing, count 4 breathing in, hold it for a second or 2, and then release it very slowly, and count 4 as you're breathing out, or say relax as you're breathing out. And if I do that repeatedly, sometimes I fall asleep.
Yep.
Does that make sense to you?
It does. It goes back to this whole question of mindfulness, right? So what you're doing and whether it be, I usually give if people are seeing me for insomnia, I'll put a couple different exercise techniques to put into their after visit summary when they see me, right? One of them is a progressive breathing exercise, and the other one's progressive relaxation. So, and this Smiling Mind app, that actually gets at both of these. It has you lay on your back, it has you close your eyes, and it has you start on your breathing. And then it says, feel your toes. Feel your toes. How often we forget about feeling our toes and that they're down there holding us up throughout the day. And so all it's doing is progressively relaxing you, starting at the very tips of your toes and the very tips of your fingers and slowly working its way up. And so the exercises that we give you, we think about you throwing a stone in a pond and the ripple effect, and it just watching those ripples fall out and holding that while those ripples are in your mind falling out, and then relaxing it back. Progressive relaxation is where it's at to really get people to wind down and get ready for sleep.
This doesn't happen very often, but sometimes I am tired, and I go to shut my eyes to go to sleep, and I will see figures floating around or something in front of my eyes, and I don't know where they came from.
Yep. All right, pathologically speaking, there's 2 things called, there's hypnopompic and hypnagogic hallucinations, all right? So one when you're falling asleep and one when you're waking up, okay? You can have these infrequently due to medications, actually. They're not typically truly pathologic unless that's a problem where it's frightening to someone, okay? I've had people that have had frightening hypnopompic hallucinations, okay? The other thing we think about them in is the setting of central disorders of hypersomnolence, narcolepsy being one of them. But usually, again, it's not this infrequent thing. But I can't honestly tell you what the impetus is brain-wise that makes that happen, but they're called hypnopompic or hypnagogic hallucinations. So.
All right. Well, I think that's our questions. I want to ask quick. Quite often, I'll be very tired and I'll go to bed and I'll fall asleep. I'll just be so exhausted and I'll wake up 20 minutes later. And then I'm wide awake and I'm like, what causes that, or what can I do?
If you get to a level of exhaustion that borders on some sort of deprivation of sleep, you are going to, we see this in chronic sleep deprivation versus acute sleep deprivation. So acute sleep deprivation, you're going to go to deeper stages of sleep quicker. And so it's the old Da Vinci, if anybody remembers how Da Vinci supposedly slept, he slept in like 20 and 30 minute pods. And so the idea is that you're probably getting to sleep very quickly and very deeply, and it's almost like taking a power nap.
Okay.
In reality, is what's actually happening.
Okay.
And we see that in acute sleep deprivation.
Okay. All right. It sounds like I have some habits to change. All right. Well, Dr. Clemmons, thank you. My goodness, lots of great information today. I have lots of notes for myself, for my husband, and my daughters. So thank you. It's been a couple of years since we've had you, and expect to be asked again here a few more years down the road. So, all right, everyone, thank you for joining us today. Just want to remind you of our upcoming programs. Wednesday, September 6th, Building Resilience and Cognitive Reserves, Implications for Successful Aging. And Tuesday, September 26th, Preventing, Detecting, and Reporting Medicare Fraud. Both of them are at 2 p.m. in this room and also available online. A couple other things of note as I talked to people when they came in, and I thought everybody would be interested to know. Number one, if you have to be a member to go on our trips. So we mailed out our flyer for our Kansas City trip in November. We are about 2/3 full, and it went out on Thursday or Friday. So if you're interested, I would probably go right upstairs and sign up or stop in tomorrow, but it's going to fill up here really soon. Number two, somebody brought up a good point. We have you sign up online for programs. And he said, I have to sign up for myself and then go through all of that, and then I have to go back and sign up my wife. If you're signing up, husband and wife like that, in where it says first name, that box, put, like my husband and I put Vicki and John, and then put your last name in. Then when I get that, I can separate the two of you for our attendance list. So don't feel like you have to do a separate registration for each of you. So, all right, that's all I have. Stay cool out there, everyone, and be safe, and hope to see you in September. Have a great day.